Good afternoon, everyone. My name is Dan Patel, and I'm from Vanderbilt University Medical Center in Nashville, Tennessee. Thank you very much to the organizing committee for inviting me to give this talk, and hope all you guys are doing well in Chile. The talk is going to be focused on laryngeal symptoms, and is it GERD, and should the reflex that we all have about reflux true in this scenario? Now, for people that might fall asleep, the answer is no, it's not all GERD, and I'm going to try to show you evidence behind it. No disclosures relevant to this presentation. So the objectives for today's talk is going to be to define what is laryngopharyngeal reflux, discuss the lack of evidence behind PPI trial, when and how should we use pH monitoring to phenotype these patients, and then discuss the important shift that's happening from GERD to laryngeal hypersensitivity, which might be the primary driver of symptom generation in most of these people. So we all know about symptoms associated with GERD. We're obviously going to focus on atypical GERD, LPR, or extraesophageal reflux. But the typical symptoms that are most commonly associated with GERD, of course, are heartburn, regurgitation, and dysphagia. And those have much higher sensitivity or specificity for GERD. When you talk about atypical reflux, their association with GERD is pretty low. And the reason is this list is very, very long and non-specific. So obviously chronic cough is one. There's chronic sore throat, there's asthma, there's hoarseness, there's throat clearing, bad breath, dental erosion, gum disease, and the list keeps going on. There's sinus strain, shortness of breath. So as you can anticipate, when you have such a long list, there are multiple pathophysiologic drivers that might actually create symptoms in this group of patients. And this is the reason why GERD is not always the answer in people that just have laryngeal symptoms. But when you talk about evaluation and cost of evaluation, if someone just has heartburn regurgitation, their cost is about $971 per patient for evaluation. But when you talk about atypical symptoms of reflux, and because they're highly non-specific, that cost is nearly more than $5,400 per patient. And the reason is, unfortunately, a lot of these patients get unnecessary continuation of PPI therapy. They get repeated testing because GERD is the primary thing that gets blamed. And unfortunately, they go from doctor to doctor because of dissatisfied care and lack of gold standard tests for LPR. So we need to keep the cost burden in mind. And the reason a lot of times things get blamed on reflux is GERD is extremely common. And so in this survey study of nearly 71,000 patients in the United States, nearly 2 in 5 patients said they had GERD symptoms in their lifetime, and nearly 1 in 3 had GERD symptoms in the past week. But it's important to recognize that PPIs only treat more of the acidity part, and if you look at how many number of people have persistent symptoms even after taking PPI, it's nearly 1 in 2, which again highlight that hypersensitivity might play a bigger role in PPI refractory patients. So again, to highlight the cost burden in total amount, for typical GERD, it's nearly $9 billion a year. For extraesophageal reflux, it's $50 billion a year. And that is almost close to the treatment burden for cancer, which is 58 burden. So this has huge cost implication. And I want to highlight that majority of this time, this cost is attributed to unnecessary use of PPI and unnecessary continuation of PPI. So even if you do an empiric PPI trial, be mindful to stop the medication if they don't respond, because a lot of these patients unfortunately just keep continuing the medication even if they had no improvement in their throat clearing or laryngeal symptoms. And that's highlighted again, of course, by survey studies on PPI. So laryngeal symptoms are not reliable, and I think that's important to again highlight. If people that have hoarseness, globus, cough, there are multiple things that can create symptoms outside of GERD, particularly ear, nose, and throat etiologies such as muscle tension dysphonia, vocal cord paralysis, irritable larynx symptoms, cancer, or even paradoxical vocal cord motion. So it is important to make sure that you have a broad differential, because it's not all Gerd. And as more and more studies are coming out, we're starting to understand a bigger role of laryngeal hypersensitivity and how nerves might be triggering the symptoms. Now, the problem, of course, with LPR is there is no gold standard test. So how is it diagnosed? Well, a lot of the times it's from a laryngoscopy. So a lot of ENT providers would do an in-office laryngoscopy test. We'll look at the vocal cords, arytenoid cartilage, and comment on, well, there is some vocal cord edema or there is ventricular obliteration, and subsequently diagnose patients with LPR. The problem is these, of course, signs are highly nonspecific and very, very subjective. Interestingly, in one of the studies, if we took healthy asymptomatic volunteers and they underwent laryngoscopy to see, well, how many times do ENT providers comment on the signs of irritation that supposedly get attributed to LPR? And it's extremely common. So in healthy asymptomatic volunteers, in the study, about 93% of them were commented on having at least one side of tissue irritation, common one being arytenoid edema, and nearly 83% even just using rigid laryngoscope. So more than 80% of patients that don't even have symptoms will have one of these signs commented by ENT. So that is not a reliable diagnosis of LPR, and that's important to keep in mind. So even though laryngoscopy findings, though, are not reliable or diagnostic of LPR, it is important to do in all your patients with laryngeal symptoms, because you need to rule out malignancy, which can mimic the symptoms in our throat. Now, it is important to look at, what is the response to PPI? And the best way to look at that is number needed to treat. So this is to put things in context. If you're talking about number needed to treat for PPI for healing of esophagitis, it is excellent. It's 1.8. If you talk about heartburn relief, it's 4.4. And if you talk about regurgitation relief, it's still really good at 6. But when you talk about laryngeal symptoms, it is virtually no better than placebo. The number needed to treat is nearly infinity, and you have to recognize that PPIs are not an effective treatment for laryngeal symptoms by themselves. And this is again shown by multiple randomized control trials. So this was a meta-analysis done on 8 RCTs, and you can clearly see there is a very high, not only a placebo response rate, but there's no significant difference between PPI versus placebo. And when you look at the forest plot and combine this 8 RCTs, looking at response rate, you can see that the relative risk is about 1.28, and it clearly crosses 1. So there is no significant benefit of PPI compared to placebo in improving laryngeal symptoms. Now, of course, this got reinforced again in a very nice pragmatic trial that got published last year using empiric PPI. And again showed a very, very low yield. So this was a pragmatic, double-blind, placebo-controlled, multi-center RCT that involved nearly 350 patients who had throat symptoms, and they randomized them to lansoprazole versus placebo. They did all the patient-reported outcome measures, including RSI, and LPR, health-related quality of life. They did objective metrics in terms of laryngoscopy findings, and you can clearly see here that at 16 weeks there were no differences between placebo versus lansoprazole, and even at 12 months there was no difference between placebo or lansoprazole. And interestingly, actually, placebo was a bit better than lansoprazole. So again, this very nicely done RCT recently, along with multiple other RCTs, show that empiric PPI trial for just throat symptoms have virtually no role in clinical practice because of very low effectiveness. So how do we approach this group of patients? Of course, we have our diagnostic toolbox, which includes upper endoscopy. We have prolonged wireless pH monitoring, which can be 48 to 96 hours, or 24-hour impedance. And the goal of this is to phenotype the patients to see, well, do they truly have reflux using this testing? So we all know the Porto consensus, which talked about how to figure out which testing might be used, and in people that have definitive evidence of reflux, such as LA grade C or D esophagitis, long segment Barrett's, or prior positive pH testing, certainly impedance on therapy is a better tool to see, well, is there reflux controlled? Because obviously symptoms might be primarily driven by non-acid reflux events. So that's on therapy testing. But in our cases for laryngeal symptoms, majority are going to be extremely low yield. And then the recommendation is to do off therapy testing in majority of our patients, either prolonged or 24-hour, 7 to 10 days off of acid blocking pills. Prolonged testing certainly has higher sensitivity compared to 24 hours to rule out the disease. So that is our preferred modality in someone with laryngeal symptoms, is to do 48 to 96-hour wireless pH monitoring, 7 to 10 days off of acid blocking pills. Now, how do you really interpret the pH testing in people with laryngeal symptoms? And that is an excellent question, because when you look at what are predictors of esophageal exit exposure, which we looked in 2018 in people with extraesophageal reflux, it's really, do they have concomitant typical symptoms of reflux? If that concomitant heartburn, their odds ratio were higher for acid exposure time, or they were overweight or obese, a BMI of 25 to 34, if that concomitant asthma or hiatal hernia were again positive predictors for abnormal acid exposure time. So this allowed us to create a score called HASPIR, which stands for heartburn, asthma, and BMI. And depending on your patient, if they have concomitant symptoms or asthma or BMI, you can figure out what testing might be helpful. And someone that has a low score, so 2 or less, the likelihood that they have abnormal reflux is pretty low. And in this scenario, doing pH testing off of acid blocking therapy is the go-to, because it will help you rule out the disease. And if this is negative, you should consider alternative etiologies such as allergy, pulmonary, or ENT. And if that all workup is negative, then laryngeal hypersensitivity is the primary cause of symptom, and you should treat it. If they're scoring high on the score in terms of they have concomitant heartburn, asthma, or BMI more than 25, their risk of positive testing is higher. So on therapy testing is better to figure out, is their reflux controlled. Now, if this testing is positive, you should obviously optimize PPI therapy, but be very cautious about considering anti-reflux surgery, because again, there is no gold standard test that's going to help you associate, well, are the laryngeal symptoms caused by the abnormal acid exposure. So we really consider anti-reflux surgery only in people that have concomitant severe regurgitation, large hiatal hernia, or moderate to severe abnormality on acid exposure time, because that might increase the likelihood of response. So abnormality on pH testing does not equal causality. And so clinical profile of patient and looking at concordance is very important. Majority of these patients have failed PPI, so we need to distinguish, well, are the symptoms from laryngeal hypersensitivity or reflux? So we tend to reserve invasive options in people that have concomitant regurgitation and the defective anti-reflux barrier, because even if the laryngeal symptoms don't get better, the regurg will, and that does improve quality of life. When you look at studies on, well, what are predictors to anti-reflux surgery in people with laryngeal symptoms, we looked at this in 1 year out from anti-reflux surgery, and it's really how bad is the acid reflux. So it is important to keep in mind that just because the pH testing is positive doesn't mean that is causing their acid reflux. So in people that had moderate to severe reflux in terms of acid exposure time of 10 to 12%, their likelihood of response to anti-reflux surgery was higher at 1 year compared to others. So we reserve it primarily in this group with laryngeal symptoms who have moderate to severe reflux on pH testing. Now, there is a lot more evidence that laryngeal symptoms might be driven by nerve hypersensitivity, and I think that's where the field is moving. It's not Gerd, but how the nerves are perceiving the signal. And this was an excellent article that talks about the urge to cough, the throat irritation. There are airway nerve targets like P2X3 that are sensitized, and blocking this nerve targets in clinical trials have been pretty effective for symptoms such as chronic cough. And so in people that have negative pH testing, think about laryngeal hypersensitivity, functional laryngeal disorder that have bothersome symptoms. You ruled out reflux, and there are no other potential etiologies after workup with sinus team, endocrine team, and laryngeal team in terms of muscle tension dysphonia. And if they meet this criteria, then treating the laryngeal hypersensitivity is much more effective than focusing on reflux. And there's obviously data behind use of gabapentin for chronic cough with 74% response rate, and even amitriptyline in an RCT with 87% response rate. So these might be the go-to medications in someone with negative pH testing or even mildly abnormal acid exposure time, because nerve hypersensitivity seems to be the major driver in the majority of patients with laryngeal symptoms. So take-home points: laryngeal symptoms, is it usually GERD? No. If they have concomitant heartburn regurgitation, you want to do empiric PPI, reasonable, but make sure to stop it if no response in 4 to 6 weeks. If no heartburn or regurg and just laryngeal symptoms, do objective pH testing as a first step rather than empiric PPI. And we need a multidisciplinary approach. We need to understand that this is not all GERD. We need to optimize care from other teams such as ENT, allergy, and pulmonary. And we're starting to understand that it's more about laryngeal hypersensitivity, which seems to be playing a major role in symptom generation rather than true reflux. And addressing that seems to be very effective. Thank you very much.